Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jeanne Sarnosky, and on today's program we're going to learn a little bit more about VNA Hospice and what is hospice care in general. We're lucky today to have with us one of our hospice nurses, Donna Dragos. So thank you, Donna, for being here today. I appreciate your time.
You're welcome, and thank you for having me.
This is always fun.
Yeah.
And I like to start with viewers getting to know who you are a little bit. So if you just tell us sort of what inspired you to get into hospice care, because that is a different field, and how long have you been?
Yes, well, I've been a nurse for 20 years in med-surg nursing. Prior to that, I was a veterinary nurse. And,
Really?
And I studied animal diseases with the intent of being a veterinarian. Pathobiology, so all of those things, plus a nurse's aide. I worked as a nurse's aide while I was studying in college. So all of those things kind of prepared me for hospice work, as well as having a lot of relatives that were great aunts and uncles, and I was the only daughter, so I tended to a lot of their deaths. Some of them were hospice attended and some of them weren't. And I saw what hospice can do, coupled with being a breast cancer survivor. So all of those things kind of merged me, and I was always attracted, being a veterinary nurse, to those patients who couldn't speak for themselves.
Yeah.
And at the end of life, I found that there was a lot of things that we could do, and that I worked with the hospice liaison nurse at the hospital, and so she kind of led me into hospice.
Wow.
Yeah.
So how long have you been with the VNA Hospice?
I've been with them for 2 years now.
Okay.
Yeah.
Yeah. Well, that's great. Well, I had no idea. That's a great backstory that you have all that other experience.
Yeah.
And it's so easily funneled into what you're doing today. It makes sense.
Yeah, I do feel like this is the culmination of a lot of my interests. It's all brought me here. So it's a calling.
Yeah.
I see it as a calling.
Lucky us.
Thank you.
So I think viewers probably still, even though hospice has become a more better known word and topic these days, there's probably still a challenge in helping people understand what it is. So do you want to talk about what is hospice exactly?
Yes, hospice is a philosophy, and it's about pain control and symptom management at the end of life. We have a team, an interdisciplinary team, that goes to where you are or where the patient is to manage symptoms. It's not a place.
It's not a place. I think there's a lot of confusion on that.
I think
hospice
so.
Is a place, and it isn't. It's just a way of caring, a philosophy of care.
It's a philosophy of caring in a team. Yes, yes, that will take care of you.
Now, when you talk about the team, I'm going to go off on one a little, because we have that, is what kind of people are on that team? So it's not you, it's you yourself, the hospice nurse, but there's so much more to it than that.
Absolutely. We work with a doctor, and that's usually your primary care physician. We have a case manager, and she kind of oversees the whole team. She's kind of in charge. And we have a social worker assigned to you. We have bereavement for family members. And we have spiritual. That is, some people like that, some people say no, and that's fine. We have a team of volunteers. They're specialized. Some of them are specialized in caring for vets. And
for veterans.
Yes, for veterans. And we have home health aides and complementary therapy. So we have all of that team, and we're all trained to recognize where our strengths are and where we need to pull in somebody from another part of the interdisciplinary team.
So of that selection of people, a patient or a client may or may not see all of them, depending on what their needs are. Like you said, the spiritual may or may not, depending on if the person is open to that, or the volunteers offering respite or support.
Yes.
May or may not.
Yes. One thing about hospice that's very unique is, and I found this different from med-surg nursing. Med-surg nursing, we come in and we say, we're going to take from you, we're going to take your vital signs, we're going to take your blood, we're going to take your tests. and then we turn around in hospice and we say, what can we do for you? And how can we make your life more comfortable? And so if the hospice patient does not want to see a spiritual person, we don't push anything on them. We don't say that they need to.
Oh, yeah.
So we work with them, and if they do have spiritual issues but are not, or do not want to see a spiritual person, then we work with that.
Okay.
Yeah.
So different. So you have the nurses providing the clinical care. You have social worker coordinating some other services that might be available? Or?
We look generally at 4 aspects of pain. It's not just physical pain, but there is physical pain, and we kind of think the nurse is kind of tending to that.
Okay.
There's social pain, and we bring in social workers. Say there's a family dynamic that needs to be healed, something like that.
Yeah.
That pain needs to be worked on.
Okay.
And emotional pain can be related to social pain, and it can be just something. A Vietnam veteran might have some emotional pain that needs to be brought out, and spiritual pain, feeling as though they have to make peace with God before. And so there's those kinds of pain, and so we separate them out, and we know that maybe medicine cannot tend to the spiritual pain, but the spiritual person can address that.
Right, right.
Yeah, so we try and make all of those areas of pain, just relieve those areas.
Right.
Yeah.
So are you there 24/7, or for someone that has hospice care in their home?
That is another kind of misnomer that I find, that people say, you're just going to come in and take care of us. We do have that whole team that comes in, and the case manager will come in as often as is needed. Usually in the beginning it's once a day, maybe even more, but we manage symptoms, and once the symptoms are managed, we can step back a little bit. But we also have a home health aide that comes in once a day for personal care, and then our other team members that come in. But we work with family members, and we work with our social services. So if family members need some relief, we bring in our social worker to determine what kind of finances are available, and what kind of community services are available, and how we can meet their needs.
So it's very much a support system for the people that are in the home.
Yes, that's a wonderful way to say it.
And there's probably a little bit of education going on for some of the caregivers?
Absolutely. We provide support and any kind of education that's needed. And again, we're available 24 hours a day by phone. So if a patient wakes up in the middle of the night and has some symptoms that need to be managed, they can call us. We have a triage nurse they will connect with, and the triage nurse will first try, she has access to the records, and she will first work on maybe some medications that might be useful to manage the symptoms. But if she cannot get those symptoms under control, she'll either designate herself or another nurse to go out
Send someone
at
out,
that time.
Yeah.
Yep. And we will work to we will stay there until those symptoms are under control. If those symptoms do not get under control, we send to the hospital. And we manage symptoms there.
And then that's also sort of a pre-established choice for people as well, because do you have some people that are at that point where they don't want to go back to the hospital? Absolutely.
And we work with the patient there. We manage symptoms at home. We can always get pain under control with pain medicines. So if the patient does not want to go to the hospital under hospice, we don't send them to the hospital. We manage symptoms at home.
Now this is a tricky question. Even as as we developed the questions ahead of time, I thought, oh, that is a good one. How do people know when it's time for hospice?
Well, there's criteria that have to be met. We can't just sign somebody up for hospice because they want it or because the doctor wants it. There's the Hospice and Palliative Care Organization has criteria that have to be met for each disease. So the doctor determines that there is a terminal illness that has 6 months or less of a lifespan. So we go in and we look at the disease process, and we look if it's cancer, the metastasis, or other kinds of disease, that we have to meet criteria. And so we look at that criteria. When that criteria has been met, we'll talk to the patient about what hospice services we have and what we have to offer.
And that criteria is established in order for all the care to be covered by insurance? Is that by Medicare?
Pretty much, yes,
pretty much?
yes. And not to get people onto hospice, you know, when they don't really need it.
Oh, okay.
Yeah, for both of those reasons, I guess.
And then there's always that question of, well, what happens after 6 months if I'm still here?
Well, there is no time limit because it's hard. It's almost impossible to determine,
say,
right? And so it's always that 6 months or less. So if 6 months go by and if the patient's doing very, very well and has improved in a lot of areas, we will sign them off of hospice and they will continue until they need us again. But if they're showing some decline, but it's not as rapid as the doctor thought, they still have that 6 months or less diagnosis, so we can re-sign them up.
Okay.
So it's not really an etched in stone.
Right. Yeah. That would be hard to determine.
Yeah.
All cases must be so different.
They are.
Yeah.
They are.
Now, there are a lot of different hospice options out there, but VNA Hospice and palliative care has some other benefits maybe for clients.
Yes. Our uniqueness is in that we have our 3 programs. We have our VNA certified, and that's, you know, when you need something, a skill from discharge from the hospital. So you've had some open heart surgery, you certainly need your vital signs taken and bandages changed, and you need a skill. So we have the certified available. Our next program is our palliative program, and that's when someone's been diagnosed with advanced disease and needs symptom management. So we provide that 24-hour nurse available, and we also provide a nurse in the home. But when those symptoms are managed, we kind of stay around because it's an advanced disease. It's not really going to be. It won't get better.
Yeah.
But the patient is still going to the hospital, getting curative treatments, say it's a cancer, getting chemotherapy, but there's symptoms to be managed that are not going away.
So it could be pain or how well they're handling the chemo, some of the other
nausea,
comfort.
Anything like that. Anything, and even anxiety, those kind of things, we manage those as well. So we're always checking in on the patient to see if there's any symptoms to be managed. And once we've got them all managed, we stay around to make sure that they stay under control and try and catch things before they get so bad that the patient does have to go to the hospital.
Right.
But they still do go to the hospital under palliative care.
Okay.
And for hospice care, it's that they've had that terminal diagnosis. They've said that this is enough. Either the patient or the doctor might say, this treatment is not working. It's not doing anything for you. Or the patient might say, I've had enough. I don't want any more, and I want to stay home. So our goal is to keep that patient comfortable in the surroundings that they're in for as long as we can and manage symptoms without having to transport them back and forth to the hospital. It's not that they can't go to the hospital, and if we can't get symptoms under control, we have that option to bring them to the hospital and manage symptoms, and we manage them under our hospice benefit. But if there's another disease or something that happens to them that's not related to the terminal illness, we bring them to the hospital and they go in, say it's a broken leg or some other kind of infection, or a pneumonia or something, then the Medicare will pay for their stay there and they can stay in the hospital and get that under control.
Okay. Now hospice, we talk about hospice at home. It's wherever someone calls home. It could be an independent living, you know, when we think of a house, but there are other places where hospice care can be provided.
Yes. Assisted livings are just like home, so we go in there. The insurance, it kind of depends. With nursing homes, we work together with them and we try to work to manage how we can go in. Sometimes, like Medicare will say that it's redundant care if patient is on their skilled benefit days. So there's fine-tuning that has to be done. So we look at each case individually to see how we might be able to go in and work with that patient under hospice care.
So it's always worth a conversation because every case is so different.
Every case is different. Everybody has different ideas about what they would like to do. Some people are absolutely wanting to pay privately for hospice care to go in as an extra added benefit into a skilled nursing facility.
Right.
That's always an option, but we look for all the different ways that we might be able to go in.
Can people that live alone still receive hospice care?
Yes, absolutely. And we go in and are
That's
part
good to
of
know.
our...
There's probably a lot of people out there
Yes,
that are by themselves.
there are, yeah. And we go in and we talk with the patient on admission and ongoing about what the next step is going to be. And we like to set up, if we can, a plan of care for when the patient cannot take care of themselves anymore. And we like to get something that they want in place and that they agree to, and we write it out and we both sign it so that we know when it comes to the time when they cannot take care of themselves anymore, they know what's going to happen, they agree with what's going to happen, and we make that happen for them.
No surprises then.
No surprises.
No surprises,
Yeah,
yes.
we try to have as few as possible.
Now, I know that for a lot of people, when they think of hospice, the cancer goes automatically with
Yes.
that. But there's more than just cancers that hospice can be helpful with.
Yes, there are a lot of other diseases that work their way to an end stage. Renal disease, cardiac disease, end stage respiratory diseases. So we're familiar with all of those, and we know when we work with the doctor, again in the interdisciplinary team, to know when it's time to start coming in and managing the symptoms, that there's nothing more that can be done to make that better. So we come in and manage the symptoms.
Okay.
Yeah.
Do people on hospice have to have a DNR, do not resuscitate?
Yeah, I'll talk a little about the do not resuscitate. That just means when your heart stops, that you do not want anybody to artificially start it again. And that is not a prerequisite to come on to hospice. When you do come on to hospice and you are what we call a full code, we do address that concern, and we keep it a little bit of an ongoing because as the disease progresses, it's always the patient's choice, but we do like the patient to understand what might happen if the heart does stop and they have a terminal illness, that they could end up on a tube for a long time while the body breaks down around them. Our medical technology is incredible. We can keep people alive for a long period of time. But what kind of quality of life is that, and what kind of suffering does that cause? So we try to let the person know what is in store if they decide to do that. And there's certain cases where they might want to do that, and we respect that up until the end. But we do try to be clear, very clear with what the choices are and what the choices that they make are and what they might see.
Is that one of the hardest parts of what you do?
I think that most people do want honesty, and I think that once that bridge is crossed and they realize that we are being honest with them, it takes them to a new level of ease and comfort and understanding. And I think with honesty and the understanding, then they let that go, and then I think that I start to see a real peace. So I don't really find that uncomfortable because I know the sense of peace happens afterwards.
Wow.
Yes.
Wow. Good work, huh?
Thanks.
So the nurses and evidently the rest of the team that are involved in hospice, is there special training for hospice care versus just nursing?
Yes, I mean the best training is hands-on, but we have a certification program, and a lot of us are going through that right now. But we also have advanced training that we do within our department on symptom management and end-of-life care. It's it's a specialty, as I said, when a med-surg nurse, we're really going for the cure, we're looking for the cure, so we have to step back in hospice and realize that, you know, our goals are very different. So there is a lot of training that we work with the different when we start, we work with all the different teams in the interdisciplinary team to find out where their goals are and what they're doing. So yeah, there's quite a bit of
a little extra training involved in something like that.
Oh yes. Yeah.
Now for the caregivers that might be in the home of a hospice patient, do we have a system for offering them some respite care or a break from?
Yes, yes, we do. And part of the hospice benefit is when we nurse the caregivers as well, and we're always assessing for caregiver burnout and if they do need a respite or what's going on in their lives every time we go in and manage the patient as well. But we offer a 5-day respite stay at a facility of their choice. We ambulance the patient over if there's a wedding or something that somebody needs to go out of town and the patient needs to be cared for. We have a way of getting the patient into a facility of their choice and paying for that so that the caregiver can either have a break or have a break in any way possible.
Yeah.
Yep.
And then are there volunteers available for the little shorter breaks that are in the home?
Yes, we do. We have volunteers and we have the home health aides that can come in so that they can go out and take care of their needs.
Right.
Yep.
So they get a little bit of a break.
Yes.
As that's a heavy load too.
Yes, and we try and bring in multiple family members if we can, or friends, we ask the patient who's there that we can work with. And frequently there's close friends that want to come over for a visit and we schedule them in. You know, and we say when family members or friends call up and say, what can we do? We say, take your calendar out and say, dinner next, Wednesday, and put them right on there. So, and we like to turn it into a very socially centered around that patient, but having people that care about that patient be involved with that patient's care on any level that they're comfortable.
Right. That's a nice feature too. Yeah.
Yeah.
Yeah. So let's say now we've had someone on hospice in our family or loved one and they pass. What happens next? Do we stay in touch with the
Yes, we
families?
do. Yes, we have a bereavement program.
Okay.
And that is a program that stays in touch with the family for 13 months. They usually call, sometimes they call and just check in, and then they wait till a month or two after, because a lot of times with the funeral and all those arrangements, there's a lot going on and they don't really settle into the fact that that patient's gone till a month or two after the patient is gone, and that's when bereavement steps in, and that's when they're ready to talk to us. So we have support groups, but we usually do a one-on-one at first, and then as people work through their grief, they find that support groups might be helpful. We have lots of resources available in the community that they might need, depending on their age, depending on the situation. Right.
And how long do we stay in touch with people then after the?
It's usually for 13 months.
Oh, yeah.
But it depends. We say
depending
13
on the
months.
Need. Yeah, definitely.
Yes. Sometimes people become volunteers. Sometimes they want to work for us.
Oh, yeah.
Yeah.
We have had some of the volunteers go that way, definitely, because they've had the experience.
Yes. Yeah.
Now, for people that are on hospice that maybe have started with us on the home care side, do they stay with some of the same caregivers because people become so familiar with their home health aide or their...
I've run into that too, that they have VNA certified and they love their nurse and they love their home health aide and they want to keep them. We transition over from certified to palliative. We start with a different nurse. The home health aides we can transition over, but the nurse is a different nurse. What we like to do is put people into the program that best is suited for them, that best meets their needs. So with the palliative program, we try to encourage their certified nurse to help them transition over into palliative, and we do the meet and greet with one of our palliative nurses. But we find that having our palliative nurses who are skilled in hospice care, it's better for them to have the palliative and transition to hospice with the same nurse. So that's how we work it out.
So once they're on palliative, they'd be likely to see the same people then through the
That's right.
whole process.
Through the whole process, they would stay with the same nurse from palliative through hospice care. So that's how they've worked it out. That's how they feel the transition works best. But I know it is heartbreaking sometimes for the patient to let go of their certified nurse.
Right.
But.
So I know there's a misnomer out there that people on hospice care or people that are under hospice care, sometimes that actually expedites the process through medication, or that maybe hospice helps things along too much.
Yes.
Do you want to just quick touch on that?
Sure, yes. No, we do nothing to hasten or prolong death. We step back and we manage the symptoms of the disease however it is going to proceed. So sometimes we get called in, frequently we get called in late in the process to hospice. So we start our medication because the patient is short of breath. We get called in because of symptoms at end of life. So we bring in some of our medicines that help those symptoms, and once the patient gets those symptoms under control, then they can relax and do the work that needs to be done in the dying process. So it looks like we come in and expedite the process, but what we're doing is we're getting the patient relaxed and ready to do the work that they've been struggling to do with those symptoms.
So ideally, we'd like to hear from people closer to the 6th-month period instead of the 6-day.
That has been our
3-day,
experience where we can do the most work and where we can have the most, and I don't want to use the word beautiful death, but it really, when we see it happen, we know it, and that's what we say is this was a beautiful death. We were able to get the patient to work out all their different kinds of pain, and the family members to understand the process and to be able to get rid of some of their, maybe they have guilt, maybe they have strong feelings one way or another that they have time to work on with the patient. So when we get that all in harmony, there's just this really nice living experience that happens, and then the dying experience is the same way, and the family members are there to say to the patient, we love you and we're going to be okay because of what you've given us. And that is
fabulous.
Fabulous.
Yeah,
yes,
that's
what we strive for.
That's what we would like for everybody.
But there's a crash course, and we do the crash course if we have to.
Very good. Well, believe it or not, we're out of time, Donna. I appreciate so much everything that you've offered today. Good information.
Thank you, and I thank you so much for giving me the opportunity to present this information.
Yep, good stuff.
Thanks.
Okay, I'm Jeanne Sarnosky, wishing you good health and good health care.